Hello, and welcome to the Center for Health Design's Research Corner, Ask the Author. Thank you for joining us. I'm Alan Card. I'm a research associate with the Center for Health Design, and I'll be your host for today's session. Before we begin, I'd like to thank the Health Environments Research and Design Journal, HERD, for providing free access to the articles we typically review. If you've not already done so, we recommend subscribing to HERD. There's a discount code for attendees to receive 20% off the subscription code using HERD20. That's HERD20. We'd also like to thank our Research Corner sponsor, PatCraft. The purpose of the Research Corner, Ask the Author, is to broaden the healthcare community's knowledge, understanding, and application of built environment research. You'll get the chance to join in with that today by asking questions of the author. Ask the author. We're really excited to help you engage with the authors of this really useful paper. Continuing education units are available for this webinar from AIA and from EDAC. To receive credit for your participation, you can download the forms at any time by clicking on the Show My Media Library icon, which is located in the top toolbar where the red arrow is pointing. You'll have access to the AIA quiz, the EDAC form, and today's presentation slides. To download a file, click on the green arrow next to the file. When you're finished, click on the double right arrow in the top left corner of the media library. The library will close and the slides will refill the empty space. For EDAC credit, complete the verification form and retain it for your records. You will need to submit the form to Castle Worldwide at the time of your renewal. For AIA credit, complete the verification quiz, purchase the CEU management fee for $10 from CHD's store, and submit the verification form to Catherine Anchetta. She'll upload the credits to your AIA account. You'll find Catherine's email address included on the form. I'd like to take a moment to review how to use the chat feature so that you can ask questions or submit comments on what you hear today. As shown on this slide, just type into the chat box where the red arrow is pointing. Be sure to chat your questions to all so that all attendees on today's call are able to see your message. If you're having any technical difficulties, please type your chat to moderator in a private conversation and we'll see how we can help. I'd now like to introduce you to the authors of the article we're going to be discussing today, Dr. Deborah Wingler and Erminia Macri. Dr. Deborah Wingler is a research assistant professor with the Center for Health Facilities Design and Testing at Clemson University and president of Healing Design Integration, LLC. Deborah's research focuses on improving the patient and staff experience within the ambulatory care environment. Her research utilizes real-time data collection techniques to elicit insight into patient and staff physiological, psychological, and neural responses to high-stress healthcare environments. Her research interests include bringing high-quality care to vulnerable populations and medically underserved communities within the United States and internationally. She holds a Master of Science in Design and Healthcare and Healing Environments from Arizona State University's Herberger Institute for Design and the Arts, and a Bachelor of Science in Chemistry from Northern Arizona University. Erminia Macri is a graduate research assistant at the Center for Healthcare Facilities Design and Testing at Clemson University, where she is also a doctoral candidate in the Planning, Design, and Built Environment program. Erminia holds a bachelor's degree in Architecture and Urban Planning, UFSC 2004 in Brazil, and a Master of Science degree in Architecture, USP 2010 in Brazil, having experience as a design practitioner on several healthcare facility projects and as a professor in architecture and healthcare hospitality management undergraduate courses. Erminia's research focuses on investigating how design supports tasks and social interactions in healthcare settings, mostly using in-depth observations and interviews. Her research interests also include the application of evidence-based design processes in healthcare design and understanding how design can better support family engagement in healthcare environments. Thank you both for joining us today.
Thank you, Alan.
As I mentioned, we're hosting this event to identify the everyday practical applications of research findings in a published article. Today's featured article, comparing the effectiveness of 4 different design media and communicating desired performance outcomes with clinical end users from the Health Environments Research and Design Journal. On today's call, we'll have an interactive discussion about different key factors in your study. And at this point, without any further ado, I'd like to turn it over to the authors who are sharing their wisdom with us. Thank you so much.
Thank you, Alan.
Thank you, Alan.
So just to kind of get started and to give you a little bit of context for where this study came from, we have been working together collectively with a larger research team on a project looking at, that has been over 4 years, looking at designing safer OR environments. And as we were working on with our clinical end users and trying to convey design information, that is really where this study kind of came from. And what we really began to understand as we started looking in the lit, first of all, we really knew that it is confirmed in the lit that there is a communication gap between designers and clinical end users during the design process. And we also know from not only the literature but practical experience that involving clinical end users early in the design process is essential, not only for designing environments that support their work practices, but also being fiscally responsible to bring design solutions and changes early into the process when it's relatively inexpensive to make those changes versus after post-occupancy when the building's already there and it can become quite costly to have to make renovations. We know from the literature that less immersive architectural representations such as floor plans and sections are less effective in helping clinical end users understand both the quality and the functionality of space. And we also know that more recently, more immersive architectural representations such as physical mock-ups and virtual mock-ups are becoming more popular. However, what we don't know really from the literature is how each of these different design media can really support both clinical end user understanding of proposed design solutions, as well as how each of the media is effective in eliciting design feedback from clinical end users and the type of design feedback that each design communication media facilitates. So as we began looking at this, we really had two very somewhat simple objectives. First, we wanted to compare the effectiveness of these different design communication media, number one, in conveying information to clinical end users, but then also understanding the type and amount of design feedback that can be garnered from these different design communication media from clinical end users. So just kind of an overview of the methods. This research design was an exploratory qualitative study. It utilized task-based simulations, and it looked at 4 different, very typical types of design communication media used today. And we looked at floor plans, which were 2D and quarter-inch scaled. We looked at perspectives that were 3D, and we had 4 visual frames of reference. Within those, we used a physical mock-up, which was 4D and 1-to-1 scale, as well as a virtual mock-up that was the same. And for the methods, we used structured interviews and a focus group. So, like I had said before, really the context for the study was an operating room prototype. And for our participants, we had a total of 13 surgical team members, 4 of which were surgeons, 3 of which were circulating nurses, 3 which were scrub nurses, and then additionally 3 anesthesiologists. So kind of just going over somewhat quickly the data collection, we used task-based simulations. So what we had were different tasks associated with the different roles in which the clinicians perform their work. So we had different tasks, for example, for the surgeon, for the anesthesiologist, and for the circulating nurse as well, that they were asked to perform in each of these design communication media. After they performed the tasks within a specific media, one of the 4 media, then they underwent an a structured interview. And the structured interviews had questions regarding the aesthetic quality, spatial attributes, and functionality of the spaces, as well as work performance and any design feedback or suggestions that they had. It's also important to note that each clinician started with a different design communication media. So it was randomized. They didn't all evaluate the same communication media in the same way, in the same line. And then after each clinical team member had evaluated each of the 4 design communication media and their associated structured interview, then a focus group with the whole team was conducted, and that had questions regarding how design understanding and evaluation was supported by each media. So I'm going to turn it over to Erminia to share with you the findings.
Thanks, Deborah. So first, we did some descriptive statistics into all the responses from the interviews. And what we found is that the physical mock-up really was consistently rated higher than any other media across all questions. And that includes aesthetic quality, spatial attributes, work performance, and functionality. Then it's really interesting to go a little bit deeper and go into each one of these characteristics of the media and kind of also understand how spontaneous commentary really foster a better understanding of how they are able to, facilitate, inform and foster design suggestions from users, from end users. So aesthetic quality is really how the space looks and how it feels. So floor plans, this is not a surprise, it was the least effective. People were not really able to understand, to provide many feedback about how they were able to understand, the appearance of the space. And then perspectives and physical mock-ups were better at that point, at that particular characteristic, and they had kind of a similar effect. And it was really interesting to understand the virtual reality mock-up because it really was the only media fostering, inspiring spontaneous commentary about how the space really felt. So people, it's kind of a thing about the virtual environment and how people really said they loved it and it was so engaging and they could really get a sense of how the space would feel. And when we look at spatial attributes, which is more about the size of the space and the spatial configuration of the spaces, floor plans were effective actually in communicating spatial configuration, but only with the assistance of the researchers conducting the task simulation, because the participants had a hard time understanding in the floor plan what was really an equipment, what was really a furniture, so they asked for the help of others. And it's really, this comment was really interesting because it's 20 by 18, my brain does not really imagine what that equals. If people have a hard time understanding from a floor plan how the space is three-dimensional, right? But then perspectives were the least effective because, people had challenges understanding the space holistically because they looked at various images of the space. So they had a hard time putting those images together, basically. They looked at a variety of views that made it kind of confusing. And then the physical mock-up was rated highest, and because it was really able to convey spatial constraints and the size and how the space was able to accommodate multiple OR team members. So, they were actually able to say that it was inadequate for gowning, for instance, like this quote mentions. When we look at work performance, and it was really how are people able to use the media to evaluate how easy the tasks are for them, and how are they able to simulate the tasks. So floor plans and perspectives were really easy to simulate movement, but again, conditioned by clarification of where, what certain equipment, certain furniture was in each drawing. So the researcher had to help them with that. And then the physical mock-up not only supported them to understand the space, but also to do it quickly and to move on to design suggestions. So that was really interesting how people easily understood what they were doing and how to simulate movement and tasks, but also quickly were able to already go to, oh, I don't like this or that, or I would prefer this the other way. And they also showed a clear preference in relation to other media. They actually verbalized, this, the physical mock-up is much clearer than the virtual reality, and it helped me really understand the space and workflow better. And then the VR mock-up actually was really difficult to simulate movement. And this is because in the virtual reality, you have a limited amount of space that you can actually physically move. So you end up teleporting, which is clicking a button and moving to another place in the room, which was really hard for people to accommodate to. It was kind of awkward. So this comment depicts that every time you hit a limit of the perimeter in the VR room to reset it, it takes away your context again and your frame of reference, and it's like starting all over. So it was kind of hard for them. About functionality, which is really how things in the space move and function, for instance, the floor plans actually were rated as highly as the physical mock-up. But then again, it was difficult to understand what things were in the actual drawing, But once they understood, they were able to, simulate their tasks. And then perspectives supported ease in identifying furniture and equipment because people saw the images, so they saw some of the details in that furniture or that equipment, so they could kind of understand that a little bit. And then the physical mock-up, again, it was not only easy to understand, the layout, visual access to other team members, how to transfer patients, but also they did that really quickly. And they actually imagined things that were not there, which was really interesting. Like they had to simulate tasks that involved surgical instruments that were actually not there. And they were able to go along and just imagine that they were there, and this facilitated the task simulation. And also the features of the characteristics of the furniture. For instance, they said, talk about the height of the monitors. So that was something that came up doing physical mock-ups too. And then the VR mock-up, again, was really a little bit difficult because they could not really mimic interaction with others because there was not other people in the virtual reality environment. And also, they talked about the sensory features of some equipment, for instance. Like, for instance, they had to move around booms, which are equipment that are connected to the ceiling. And they actually know that the equipment is really heavy, but in the virtual reality it was really light. So they kind of felt that was a little bit awkward. And then design feedback. It's not only interesting to see that the physical mock-up really inspired more design feedback, but also the types. So, for instance, the floor plans really were more, the design suggestions were more about adding or moving design elements in the space. And then perspectives is more about adjusting, the features of the equipment. And then the physical mock-up was kind of everything, all of those things. And the VR mock-up was really not as good for design suggestions, did not elicit many design suggestions. So, overall conclusions of this is that all these media, they help, but in different ways, right? So floor plans may be more useful for spatial mapping, simulating movement and flows and spatial configuration, like how spaces are connected to each other, for instance. Perspectives may be more useful for visualizing materials and their appearance. And physical mock-ups really are useful for task simulations, and they really do foster more design feedback and also require less time from end users, which we know, especially clinical end users, it's a hard time to get their time. And then the VR mock-up may be more useful to understand how design components can be assembled. And now I give it back to Deborah.
Well, thank you, Armenia. So some of the design implications that we can take away from this is that it is really important to simulate real-world tasks and to test design solutions early in the process because clinical end users really do have a lot to contribute to how the design can support their work practices. We also really can say that in many regards, the floor plans, they really convey very limited information, but more importantly, they really do limit the amount and the type of design feedback that you are going to garner from clinical end users. And doesn't necessarily leverage their ability in which to provide useful information. So we know that floor plans, they help to convey overall flow, and they do support feedback regarding maybe moving in and out different features, but that's predominantly it. Perspectives, they can be actually very challenging for clinical end users to understand spatially. And what we found was, if you could kind of see in that image of the perspectives when we showed it at the beginning, on each of the 4 visual frames of reference, there was also a very small floor plan to the right-hand corner, which was used to just show them the perspective in which the vantage point was being viewed from. And we've constantly found our clinical end users needing to reference that small floor plan to even begin to understand what that visual frame of reference was referring to. And therefore, they found it very difficult to really imagine how they would actually conduct their work in that space. So while it was useful for really helping to convey the aesthetic quality, it was not really effective in helping them understand how well it would support the functions that it needed to. And then in VR, it was really interesting. Like Erminia had said, it definitely got the greatest aha response. And it's important to note that in our VR, all of the elements, design elements, had functional capabilities. So you could, with the hand controllers, move the boom. You could move or throw around the kick bucket as desired. You could move around the nurse workstation and the garbage cans and the anesthesia equipment. All of that was movable. And while it was all movable and they had the same opportunity to move those elements around as needed to perform their work, it did not give them the same effect as being in the physical mock-up. And that is largely due to what Erminia had said, which was the lack of sensory engagement with those features. So when you push a trash can, it has some resistance, right? And without that resistance, and without that feedback from the environment itself, they found it very difficult to actually conduct their work. And then therefore, they spent so much effort trying to do their task-based simulation that they had very few design suggestions, although they loved being in the virtual environment. So I think that's something to really kind of keep in mind. And because of that, then, I think it, again, really leads to the discussion about how we value using a physical mock-up. And I think that this really would suggest that still, the physical mock-up is one of the most valuable ways for garnering design feedback from clinical end users and for garnering different types of feedback from clinical end users. And the additional costs associated with using a physical mock-up really should be also considered in terms of monetary savings for designing it right, or as close to right, the first time as possible. Some of the limitations, I think it is very important to note regarding this study. It was a very, very small sample, and it was really intended to just kind of be a pilot study and to help us really begin to understand some of the things that we were experiencing working with our clinical team and to really begin to get deeper into the why. I think many of us know that there are limitations to each of this design communication media, but I think really being able to understand and parse out what each media was effectively conveying was very helpful for us in continuing this dialogue with our clinical end users. Another limitation that I think is important to note is that a few of our participants had already seen the OR design, either in floor plan or perspective form. And so they may have already had a predisposition to how they were viewing it. And I also think it's important to note that future research really is needed to evaluate the media in terms of its effectiveness for different types of projects. And really for leveraging task-based simulations, which we know are the most effective way for clinical end users to provide feedback. And also visualization of a project and then how information is being presented. So kind of to wrap up our discussion, physical and virtual mock-ups really required much less translation from the researchers as far as understanding the environment holistically. And as Erminia mentioned, the physical mock-up wasn't just more effective and they liked it more. It really did increase the speed in which they could perform their tasks, but also the way they provided design feedback. It was much more descriptive, it was much more holistic, and it involved not just their own physical space, but it involved the space of others on the team as well. And I think it's really also important to note, because there's been a lot of talk about how to and when to leverage VR mock-ups recently. I think it's really important to note that VR really does actually foster positive reactions and a motivation from clinicians to begin to understand the space. But with its current technology, although arguably it is moving quite rapidly, it is still limited in many regards, predominantly in two aspects. Interfacing with other individuals within the VR platform. Can it be done? Yes. But it still is a very different thing than being able to look across at your clinical team member and be standing across from them. And also this issue of the sensory component. Yes, you can move components all around in VR, but it is not the same as physically holding a surgical instrument. It is not the same as actually physically moving the boom. And so I think that it has very much a place, but understanding the place in which the VR mock-up sits today. It cannot answer or provide all of the design feedback from your clinical team members that would be efficacious in designing a model for them in which they can practice their work very, very well. So I think, is that
I guess so. Thank you so much for that really impressive presentation of a really, really super interesting paper. I'll get back to that in a second, but before we move on to the Q&A session, I'd like to let everyone know to save the date for the next Research Corner Ask the Author series on February 6th. Our feature authors will be Kirk Hamilton and Arsalan Garavez. And please be sure to check out our events page on the Center's website to see our upcoming events, of which you can see there are already some for the new year. And again, I'd like to thank HERD, the Health Environments Research and Design Journal, for providing free access to the articles we discuss. Be sure to subscribe to the journal using code HERD20 for 20% off. And thanks to PatCraft for sponsoring our Research Corner Ask the Author events. Very grateful. And now it is your turn to ask questions of the authors. Please feel free to type in any questions you may have, and we'll try to answer them. As we wait for other people to start populating those questions, I think I'll jump right in. Your study focused a lot on task-based simulations versus unstructured interaction. I've seen some really interesting, even just VR interaction things on the floor of the Healthcare Design Expo Hall. Why did you choose to go with task-based simulation, and how did you choose the tasks?
Oh, that's two. Question number one, why task-based simulations? Well, because we know that clinical end users respond best when simulating real-world tasks in this new proposed environment in which to provide feedback. And it's helpful for them because it really shows them the areas and the places which truly just will absolutely not work. And then it also helps them to visualize and see things that could be a potential for working. It also really helps them to further articulate why or why not things would work well or not well for them. And so that's where the task-based simulations come into play as far as using that in our research designs. And we use that both in the physical mock-ups and in the virtual mock-ups. So we have done a lot with that. How we develop the task-based simulations. So we work very closely with our clinical team members to ensure that the tasks that we are asking are very representative of very typical tasks that they would be doing to perform their job. And it's also tasks that are they do them the most, right? When they're doing their work. And so ensuring that they are interfacing with the touch points in the environment that they would most often interface with while doing their work. So we work very closely with our clinical team members to ensure that we are aligning them with how they do their work.
Fantastic. And I meant to say at the start of this, as somebody who is directionally challenged and spatially challenged, and for whom a nice, beautifully rendered floor plan is almost entirely meaningless, thank you so much for doing this work, because I agree with your clinical folks that the being able to understand how something works spatially just does not work for me from a flat piece of paper. Ellen
right, you know, you're not alone. You're not alone.
Yeah.
And what I was going to say is that also when we do the task-based scenarios, it's very straightforward within the physical mock-up. But when you are doing task-based scenarios in a virtual reality mock-up, you do also have an added layer of not just layering in the actual tasks, but because the virtual reality platform does not respond sensory-wise in the same way the physical environment does, you end up also designing along with those tasks what we would call metaphors in the virtual environment in which to simulate the real world task. So that also kind of shows you a little bit of that discrepancy in clinical end users' ability, or why it takes more cognitive work to do the task-based simulations in the virtual reality mockup.
And that reminds me, you talked about doing these task-based simulations on these various design communication approaches. How did you do that with the floor plan? You said they were able, once with some guidance, they were able to figure it out, but what did that look like?
Could you please draw for me on the floor plan, XYZ task, where you would need to go and what you would need to do in order to complete this task? And they would just draw it, either, point to it with their finger or draw it with a pen.
Yeah, and the perspective, they just point, I would go here, I would do this. And then we noticed, were they able to figure out, where they were placing things, where the, component of the boom was that they could really, move it with, like the monitors, stuff like that.
Cool. We have a question here. Do you think there's a good way to use these methods in a combined format to generate enthusiasm and get the most effective results?
Oh, absolutely. And that's really what we say at the end. It's not really, none of these are within themselves a panacea, right? It is knowing how to use them, when to use them, but also understanding the level and the amount and type of feedback that you're going to get from each one, right? So we go back to floor plans. It's not just because they convey limited information does not mean that they are useless within the design process. They can be actually very useful just for looking at adjacencies and overall flow and ironing out some of those early details before you put the effort into the physical mock-up and the virtual mock-up, because those are money. I mean, they take money to develop.
And that's what I was going to say. It is attached to the phase of the project, early on decisions that are just about, are we having or not, an adjacent room in the OR, which is something we've been discussing for so long. Are we putting a room here or there? Are we placing the door here or there? They are able to understand that through a floor plan. But when the discussion is more about, the components of the equipment, for instance, so maybe, some perspective image might help, but then you also need the floor plan to kind of guide them through that. So then it becomes a progressive combination of those tools to, in each phase of the process, make them understand everything together. And like we said, the VR, it's really a great opportunity to maybe embed some of more features that would foster, maybe a bit more of the aesthetics of the room or other things that, and that's why we mentioned this tool, there's a lot of room for improvement of this tool, because I think it can be really helpful for some other details and how to assemble equipment together, furniture, stuff like that.
Mm-hmm. That leads into another question, this one by Ellen, and it's, do you have any suggestions on which methods might be best for an iterative process of changes? Not necessarily right there on the fly, but for an ongoing process.
Yeah. So one of the things that we have found is really critical in getting this design feedback is that you do it from two approaches, one from the individual and one from the group as a collective. And it's really essential to do both of those things. There are different ways in which you can garner that information. You can use interviews, you can use surveys to do kind of more of that individual approach. And focus groups do work very, very well for work, kind of that combined group. But it's important, what we have found is that while focus groups will help you understand somewhat the team dynamic, often you may not get the intricacies of what an individual needs in their predominant workspace, right? Because they're all sharing workspace. They're interacting and interfacing at different points in their workspace, but they all have kind of a predominant area in which they work. And so we have found that regardless of the methods, you choose a method in which you can get both individual and then collective feedback as a whole. And then really look to layer them in the analysis and synthesis of your data to understand individual needs, wants, mandates, and capabilities, as well as those of the collective team.
And again, that's a great segue into the next question, which is, did you do a follow-up physical or VR mock-up that represents end-user feedback and comments? We've all been in design meetings where the clients think they want to change, but once it's executed, realize either they like the first design or it's still not right.
It's a great question.
Yeah,
so this was conducted early on in our iterative design process. And so the answer is yes. We have been through many, many iterations of design since this study was actually conducted. What has been interesting is largely the main design has changed, but the components and the orientation and the placement of those components within the larger scale of the design are what have really changed based upon the user feedback. And it is, I agree, it's always interesting when you make a major change for one clinical team and they really like it, and then you get the second clinical team in and they say, oh, no, this doesn't really work for us. Yeah. And so how do you work then to merge that feedback to create a design that works for all?
And one thing that we did also was keep, for instance, in the physical mock-up, we kept a lot of elements flexible so we could move things around. And we maintained them in the second round of simulation. So our simulation is not, right, like they have been refining as we in each round. And we keep them in multiple rounds so that we're really sure that is what they really prefer. And then we test with multiple types of end users, like with nurses and with surgeons. One thing it was really interesting is that it is really interesting to see one simulation with just nurses and then the other one involving other team members as well, because the opinions may change. And so it's really good to keep that sometimes, remove the other parts so they can actually be more honest about what they're saying too. So that was kind of interesting. But definitely, like we test them multiple times, maybe more refined, like the doors and the nurse workstation that we tested, we kept refining them. But those characteristics was still being evaluated, like to really make sure that they are still, with the same opinion as the design progresses.
And we just finished our 6th round of evaluations.
Yeah.
So.
Wow, that's awesome. That was really cool. You mentioning the hierarchical nature of healthcare teams, which I've seen plays out interestingly a lot of the time. Were there any other ways in which you got different kinds of feedback from different members of your stakeholder groups? Because I saw you had a pretty good mix of people that you were looking at.
Yeah, I think it really goes to what Armenia said. We've done different things where we divided our teams. So it was only the nursing group there, only the surgeons, only the anesthesia team, those types of things. That's been really effective. But then also seeing that interaction between them is also very, very effective. So we've, kind of had the privilege of being able to see it from all angles.
We have another question on a related note. It's were your surgeons from multiple specialties, such as ortho, cardiovascular, general surgery, et cetera? And the same question applies to the nurses.
Thank you. That's a great question. So we have done this with two sets of types of surgeons and teams. It's really, we do it in clinical teams. So we had those that were pediatric and those that were orthopedic. So those are predominantly the two that we have tested.
Very cool. You mentioned that in some versions of VR, you can see more than one person in the room, even though it's not the same as interacting with them normally, and in some you can't. In your tests, were they able to see other team members and interact with them in that way?
No, we did not have any avatars. So you were solely in the room by yourself and then able to move around any of the components that you wanted to. Within that room, we utilized teleportation. So that is kind of a fancy word for saying that instead of walking, that they could kind of just teleport themselves to the space where they wanted to be. They could also walk around, but size was a little bit of a limitation in that regard. And then to interact with the components, they would use their handheld controller in order to reach up to the component. The component would highlight yellow, and then they would be able to move the component anywhere that they wanted.
One thing that makes me think of, which obviously beyond the scope of the current research, is it's a handy piece of language for all of us research folks. Do you have any thoughts on the possibility of augmented reality as an approach to merging, say, a physical mock-up and certain virtual reality elements for things that are more difficult for you to build in the physical mock-up?
Yeah, I think all of it has a place, right? And it will continue, its effectiveness will continue to increase as that platform, the fidelity of that platform increases, right? And we're seeing rapid changes in VR. So I also think it's really important to understand the time in which this is situated and where, VR's capabilities and limitations as it existed when we did this. And who knows, at some point, will it be of a fidelity that truly can represent the physical mock-up? I'm not sure, but this I can tell you, it will all cost money. So, developing those is not like it's just cheap and easy. They take time, they take effort, they take money. So,
but as you mentioned, I think we were privileged to be working in a university where we have multiple researchers that are also, people that are VR experts that are really interested in developing that too. And we actually have developed to our most recent VR simulations, the one that we did at HCD had some avatars, and I think, the aesthetic quality of the space really improved, I think. And we've been trying to, how to talk between, Revit and the VR platform. And so I think it's just a matter of time, but they're really interested in developing there too. So I really do see that moving forward, and we've seen a little bit of that already.
That's cool. And that sort of partnership makes me wonder another thing. How did you maintain the engagement of your clinical stakeholders over the course of, I think you said 6 or 9 different iterations of this? They've been
awesome.
I know sometimes it's hard to get healthcare folks to show up to one meeting. 6 or 9 iterations sounds like a fair number. What were the engagement approaches that you used to keep them on board?
Well, I think, like I said, I go back to the very beginning, and it's really important to note that this is, a much smaller study in the perspective of a much larger study, that we've been working on with our clinical team for the last 4 years. And they have been amazing and incredibly engaged during this time. So it really goes back to, we're super fortunate. We've had the full support of MUSC to ensure that we have clinical team members available And when they come, they are phenomenal for, just doing what it is that we're asking them to do. And it's been really exciting to see. We don't always have the same clinical team members. A lot of times we get new ones in, and it's really exciting to see them really consider things that they have not considered, that obviously impact their work, but it's just not where their predominant thinking is. And so we get a lot of really fun ahas from our clinical team members too. And I think those ahas help to keep them engaged because they begin to see something that they really hadn't given much thought to.
Yeah,
especially when they see a design intervention that will make their life quite a bit easier.
Yeah, and I've been hearing from the leaders in the team from MUC that their staff is really loving this, like having a voice, basically, or I think giving them a voice to, and they're actually building their own surgical center, so that's also part of it, right? Like they're about to, some of the staff is about to work in this new center that our research is connected to that, so that's another part of it too.
I bet you guys are good for turnover there. You don't want to go to all the work of helping build a place that's designed specifically to support your work and then go run off to another hospital built in 1974.
Yeah. That would be challenging.
Ellen says, given Herminia's comment and the presentation comment about perceived ROI, do you have any plans to quantify the value of more expensive versions of the representation or comparing them by method and or phase? What were the costs for the different methods, order of magnitude at least?
Well, order of magnitude, I think, is pretty explanatory. It really went floor plans, perspectives, VR, and then physical mock-up. Associating an ROI is really, really challenging, and let me tell you why. Other than floor plans and perspectives, although somewhat perspectives, the level of fidelity greatly determines the cost, right? So you can do quite a bit with somewhat of a low fidelity physical mock-up and get a pretty good bang for your buck, right? I mean, you're going to get a lot of design suggestions and, if you can get it to the, right level of fidelity. Of course, you're going to get more if you bring it to a really high fidelity, and they can do things such as even deciding the height of electrical outlets and where they go, right? But that's a separate level. The same is true with VR. Although people would say VR is quote, less expensive or much quicker, sure, if you want a strip version. But if you want a version that is highly interactive, that has also embedded in it the the aesthetic qualities that you're hoping to convey, that takes time, and that is not inexpensive. So it really depends. Associating a cost is difficult, but that is the kind of level and range, and it just depends on the level of fidelity in which you want to take each of those.
A related question to that is, I have heard that the level of fidelity and detail that you use in the VR model impacts the likelihood of people getting motion sick. Did that also influence the level of fidelity that you went with, and did you run into any problems with that? Because the physical mock-up generally does not make people motion sick.
We have used VR quite a bit. We have not had any problems with people getting motion sick, but that is attributed to the higher fidelity in which we are using the VR. So we have not experienced that in our simulations.
Ellen was clarifying on her question about order of magnitude. She meant about how many zeros associated at the end of the number with the various methods, closer to the actual dollar.
I'm still not going to commit to that because it goes back to the level of fidelity. And really, truly, I know physical mock-ups that have been really, really pricey, right? And I know some that haven't been. And so, and same with VR and all of that, so.
You're starting to do the Sunday shows for a political party soon, I think. You talked a lot about how this work should influence design decisions. Can you also talk about the implications for research and researchers and how these findings are influencing your own ongoing work?
Yeah, I can. So, as researchers, really what we aspire to do is garner information in which we can distill meaningful results, right? And then best is when it can be practically applied to any project. And I think, I go back to why we started this. And we were finding that we thought we were conveying some things, but maybe we weren't. We needed to understand what we were and we were not conveying, and how to convey our design ideas and solutions in the most effective way for our clinical end users to not just understand them, but then to help us do a better job designing. And so it is really important from a research perspective to take a step back and to say, am I really getting the information that I'm wanting, hoping, and needing to get in order to make a really valued suggestion, decision, and then therefore to apply it to a potential project? So that's, I think what's most meaningful from the research perspective.
But I think it's wonderful because I think one of the challenges in design research is access to facilities and, to really, and the cost of building things. And I think VR is just wonderful in that way because we get to, like we're now recruiting participants for the waiting room study and for various studies that are on the horizon. So it's really helpful.
Fantastic. Now, you talked about some of the aha moments that the healthcare folks had, the clinicians. I wonder, did you have any aha moments of your own? You said there are some things you thought you were communicating that you weren't. And what helped to raise those for you? What brought them up?
I think one of the collective team's ahas was we felt like we were very clearly conveying some of our really overarching Sentinel design decisions in our floor plans really well. And what we found was that only until they went into the physical mock-up where they really, then it kind of clicked. Like it was, oh yeah, now I see it. And so it was really, I think for us, was really seeing kind of that flip switch for them. It's not that the floor plans didn't convey information, they did, but when they got in the physical mock-up, then they actually begin to, yeah, I see it, I get it, that will work or that won't work. And so I think those were kind of some of the fun moments. And also I think it was also really fun. Oh, go ahead.
Yeah. Yeah, the fun part, I agree. I was going to say something about that too, but the thing about the perspective is that really is hard to, like they had a beautiful image, but they just don't put everything together. Like you look at individual images and it's great and they get to see some details and like the finishings and stuff, but really they have no idea how big the room is. So that, and also the fun is the VR because they have fun in the VR. Definitely, it is definitely. So this is my aha thing: is the engagement that the VR provides because people look forward to it. You get people because they like video games. So you get people like, yeah, let's do it. Let's have some fun, and that becomes part of the process for us. But for them, it's fun. Yeah. I would agree.
Tempted to start jumping up on the surgical bed.
Like throwing the kick bucket to all kinds of fun. Yeah, definitely all kinds of fun.
But sadly, that may reflect reality in some ORs. I'm not sure. Meredith asks, will this study evaluate effectiveness of communication design to clinicians? Could you comment on effective methods for communicating clinical data to designers?
That's a good question.
That's really good. So that is beyond the scope of this study, the way we're phrasing it. But yes. So, this goes back to almost to Alan's question of what methods to use, right? And making sure that you are using methods that allow your clinicians to explain the how and the why. So not just does this work for you, yes or no, but why? Because if you understand the why behind it, then you may realize that you could even provide a better solution, or exactly why it needs to stay that way, why it's a non-negotiable, that it just really needs to be here. And so it goes back to those layering the data that you're getting and providing them multiple avenues and ways in which to voice their opinions. And I also think this goes back to a little bit of the hierarchical nature of healthcare, and ensuring that you give equal opportunity to all voices in the room to express their opinion in some form or fashion. And at times that can be challenging with just an open-ended response, focus group kind of a thing.
Well, I would say that, summing it up is about summarizing, just to your question, this has been a challenge for me because I come from design, and it's been really hard sometimes to see even what it means, like what clinical data means. And I absolutely think that Deborah does a great job with that. She's it's visual, creating a very deep and clinical and very confusing information into very visual information. And it's about summarizing data, basically, and to create the connection with design that is about changing the design and making it, in fact, another way, not the other way around, if that makes sense. It's not. Mm-hmm. I think it's a challenge, but I think, and that's what I found most meaningful in research. Actually, that's why I came to the research, because it's really hard to make that connection. But I think it's about summarizing visually data, if that makes any sense.
Sure. Well, thank you both so much. This has been fantastic, especially for, again, somebody who is spatially challenged. To see you pushing the work in a direction that makes things more comprehensible to me. I really appreciate it.
Not a problem.
Thank you for the opportunity.
And again, thanks very much. And this concludes our event. We'll leave the webinar on for another 15 minutes or so that you can download the EDAC and AIA CEU forms. Thanks again for joining us, everyone, and have a great day.
Thank you.